Thank you, Sai. We can see you, so that's good sign. Can you unmute and can we, if we could see if we could hear you? Jude, if you could unmute Sai, please.
Okay, sir.
Yeah, it doesn't let you unmute on your own. So
no. So I think what will happen is that Jude will unmute Sai, you, me, and Monisha, so that we can stay unmuted. So long as we are mindful of it. But if we need to mute ourselves, we can still do it. But Jude will have to unmute again. Okay, so we got a number of participants. Can I welcome you all and say thank you for joining in? We still have 2 to 3 minutes before we start, but I thought I'd just welcome you while we are waiting. Ladies and gentlemen, welcome. So this is 3 o'clock. We should make a start. My name is Ravi Mahajan. I'm the Director for Critical Care Integration and Transformation. As you know, on the 6th of this month, we formally launched the Center of Clinical Excellence in Critical Care, and that has been quite a successful launch. And one of the functions of the center is going to be ongoing rolling program of Apollo Knowledge Series. And this is the second of the programs in the series. I'm really, it gives me great pleasure to welcome 2 great speakers today. Monisha is Senior Staff Nurse at Vanagram Intensive Care Unit in Chennai, and Dr. Sai Harnath, who is a Senior Consultant Critical Care and also Consultant Pulmonologist based at Hyderabad, Jubilee Hills. Great colleague, but also quite an expert in the matters of EICU, which is going to be another function of the center that I mentioned. We will be overseeing a network of hubs and spokes expanding, and you will all be part of it one way or the other. So welcome, and it's a great topic here to learn about, which I found in my clinical practice to be one of the most challenging things to do, which was the control of acute bronchospasm, but also one of the most rewarding things that as soon as you get the control, the patients patient feels so good and so thankful, but you also have such a sigh of relief and professional satisfaction. So a great topic to touch today. And may I invite to start Ms. Monisha, please, to start us off on this topic of management of acute bronchospasm. Monisha, all yours, please. Thank you.
Thank you, sir. Okay, namaste to all, and myself Monisha, and a senior staff nurse at Apollo Specialty Hospitals, Vanagaram. It's my pleasure to talk with you all, and today I'm going to discuss about the topic which is called as bronchospasm. Bronchospasm is a tightening of the muscles that lines the airway, bronchi in the lungs. When these airways tightens, your airways narrow, and the narrow airways do not let air during inhalation and exhalation, which is a process called as ventilation, that limits the amount of oxygen that enters into your blood and the amount of carbon dioxide that leaves your blood. That is called as a diffusion, and which also leads to decreased oxygen level in our blood, which is all called as a perfusion. Bronchospasm often affects people with asthma and any allergies and obstructive pulmonary disease. It contributes to asthmatic symptoms like wheeze and shortness of breath and whistling sounds due to constricted airways. And what will be the common symptoms? The patient will have that wheezing and chest tightness and shortness of breath will be there. And what are the common causes for bronchospasm are any allergic reaction to medication or food or any other pollens or any other substances which will contribute to bronchospasm. And second one is common cold. If the person having common cold, it also causes some bronchospasm. And any other environment irritants such as aerosolized sprays and changes in weather or cigarette smoke or fumes, fragrances or odors, as well as stress and emotional imbalances. And exercise of if the patient is having any other pre-existing asthma, any other thing, if they do exercise, means the patient will have a bronchospasm. And medication used during surgery and anesthetic drugs also cause the bronchospasm, and any aspirin induced bronchospasm and seasonal allergies. And let me move to the pathophysiology. In this pathophysiology, any of the common causes we discussed above that can be that are aggravating factors, any common causes, airways and the mucous membrane that stimulates a parasympathetic nerve, which turns acetylcholine. Actually, the acetylcholine is a predominant parasympathetic neurotransmitter in airways. It is released from airway neurons or any non-neuronal cells also. Such airway epithelial cells or binds muscarinic M1, M2, M3 receptors. These receptors are found in the epithelial cells, smooth muscles, and some submucosal gland. And the binding of acetylcholine to the muscarinic receptors triggers the host into the downstream effect. Here the downstream effect are three, and global cell metaplasia and increased mucus protection. And second one is inflammation, and third one will be the bronchoconstriction and any other airway hyperactivity and airway smooth muscle thickening and extracellular matrix deposition. And here the picture we can able to see that before downstream effect, the airways are good and muscles are good and the air sacs are filled with air. Here after that downstream effect, the airways filled with mucus and muscles are contracted and the airway swells will be there. And what are the modalities that we can use to diagnose that the patient is having the bronchospasm? First will be the pulmonary function or a breathing test. It is also called as a spirometry test. In this test, the patient is asked to breathe into the tube that is connected into the device, which is called as a spirometer. Based on that level, we can categorize conditions. The spirometer measures the force of the air as you breathe in and out. The normal range would be the 70%, or if the patient will having the moderate lung condition means it will be 60 to 65, and severe condition means is less than 60. In this, nurses have the main responsibility to monitor these recordings actually. And second one was a lung volume test. In this lung volume test, the patient was asked into the shallow cubicle room that is also called as a body box, and they have that is on device, and their nose was clipped because to reduce the escape of air. And in this test, the nurses have the main responsibility whether to check that patient have had bronchodilators, because they should not take any bronchodilators before this test, and the patient should not have over meal diet. That means the patient will have bland diet. That and all, the nurse should educate the patient before itself. And regarding lung diffusion capacity, this is also, you breathe in and out through a tube and see how well the oxygen gets into your blood. During this test, we can also monitor the hemoglobin, a protein which helps to transport oxygen into your blood. And in this procedure, the mouthpiece was placed around the mouth of the patient, and that fixed snugly, and a small amount of carbon monoxide was also added, and the patient was advised to have a shallow breath for 10 seconds, and that was collected into the container, and they will send to the analysis. And next diagnostic procedure is pulse oximeter. A device is clipped into our finger to measure the oxygen level in our blood, and eucapnic voluntary hyperventilation. This is a proactive test. If the patient is having the exercise-induced bronchospasm, means we can use this test to diagnose that exercise-induced bronchospasm. In this test, we have to know the patient. The patient should have the bronchodilators even before this procedure, and should not have. The patient should not take any alcohol before this procedure, and we have to educate the patients about this procedure. In this test, the test is used to diagnose the exercise-induced bronchospasm. You breathe in a mixture of gas. That is 21% of oxygen will be there, and 5% of carbon dioxide will be there, and balanced nitrogen will be there. And the next modality of diagnostic measure is chest X-ray and computer tomography. This diagnosis can also be done by the physician for further detail and examinations. While going for talking about the treatment, there is the most 3 common types of bronchodilators: ABT, the mnemonic which we can remember easily was ABT, was A stands for anticholinergics, and B beta agonist, and T for theophylline. Some of the short-acting bronchodilators are these medicines used to quick relief of bronchospasm and start working to widen the airways within a few minutes, and the effects last for up to 4 hours only. And some of the short-acting bronchodilators we are using here, such as Aquinib or Proair and Ventilon, and or the inhalers and nebulizers we are using here. And let me discussing about the long-acting bronchodilators. These medicines keep an airway open up for 12 hours, but longer than start working. Some of the examples are Adivir and Sembricot. These are the medicines which are available in the combination of nebulizers and inhalers. And inhaled steroids, these drugs bring down swelling in our airways. They are used to for long-term control of bronchospasm. They also take longer to start work than short-acting bronchodilators. And these are available in the oral and intravenous steroids form. And during the treatment modality, the main nurse's responsibilities are to follow the 10 rights of medication administration. You should follow what are the 10 rights of medication administration, and also you have to educate the patients about what is in medicine and what is the action of that medicine, and for what you are giving that medicine, and also educate the patient what are the side effects he may get after taking this medicines also. And this is a slide about technique to use the inhalers, because the nurses plays a vital role in that, because we are being with the patient for a long time. We had that responsibility to do that. And we had a lot of inhalers, like moist inhalers and dry powders inhalers. Some of the things only have enlisted. And first one is pressurized meter dose inhalers. And how to use means it will be on puff like container, and we have to first remove the cap and we should shake the inhalers and breathe out gently, and place your mouthpiece between the lips and activate the inhaler and breathe so slowly and deeply for low IFR, and hold breath for 5 to 10 seconds, then breathe out and wait for a few seconds and repeat the process again and replace the cap. And coming to dry powdered inhalers, first the nurse should remove the cap and prime device for delivery, and breathe out gently, place mouthpiece between the lips as it is before, and with inhaler and breathe steady and deeply. With turbo inhaler or hand inhaler, breathe in as deeply as possible and hold breath for 5 to 10 seconds. Wait for some few seconds and repeat the process for second dose if required, and replace that inhaler cap. And this is about how to use the spacers. We have inhalers plus spacers also. Let me discuss on further slides. Spacer means shake the spacer and fit the inhaler into the spacer opening. We have to fix that inhaler into the spacer opening. Put the spacer mouthpiece into your mouth and seal your lips around it. If the spacer has a mask, make sure it seals around your nose or mouth, and press the inhaler once only. Breathe in slowly and deeply through the spacer mouthpiece, and take 6 normal breaths and take spacer out of your mouth, and repeat these steps if you need more doses. This is a picture that how to use a spacer, and this is a spacer and this is an inhaler. First, in this spacer, you have to fix the inhaler, and you have to remove the cap and shake the inhalers, and insert the inhaler into the spacer and breathe out all the way, and press down on the inhaler, slowly breathe in, and hold breathe for 10 seconds and slowly breathe out. As a nurse, we have a lot of responsibilities and handling of patient with bronchospasm. Some of the nursing care plans are ineffective airway pattern and ineffective airway clearance and knowledge deficit and anxiety. The patient will have anxiety and activity intolerance, because they are very dyspneic, and they will have the conversational dyspnea also, and prevention of asthma, and interpreted family process and fatigue. And some of the nursing process I have enlisted. As a nurse, first you have to assess the if the patient is having ineffective airway clearance, as a nurse, what are the things you have to monitor? Means you have to assess the client's vital signs and needed while in distress, because the patient will have increased respiratory rate, and also some hemodynamical instability was there, like hypoxia he may have, and increased heart rate he may have. For that, you have to assess the client's vital signs, and assess for respiratory rate and depth and rhythm. You have to make sure that your respiratory rate, you are assessing your respiratory rate, because the patient will be a tachypneic or anything. And assess the anxiety level, because the patient is having some dyspnea, and they'll have for sure he or she'll be very anxiety, and you have to console them, and providing a psychological support to the patients, and speaking good words to them, like that. And assess a breath sound and adventurous sounds such as a wheeze or stridors. Some patients will have an audible wheeze, like that we can easily find out that, and we have the responsibility to know to know that and escalate to the doctors, and assess the relationship of inspiration and expiration. And assess for dyspnea, flaring of nose. If the patient was having dyspnea, the signs of dyspnea we have to check. Flaring of nose is not there, or chest retraction is there or not, or use of any accessory muscle, because the patient was using the abdominal muscle to breathe or anything. You have to assess, and assess for conversational dyspnea, as I said before, and assess for fatigue, because the patient will have the dyspnea. The patient confirmly will be tired, and you have to check for that. That also leads to respiratory failure also. And monitor oxygen saturation, and assess the presence of paradoxal pulse of 12 mm or greater. The therapeutic intervention. What are the therapeutic intervention? The nursing intervention, we don't want any orders from the doctors. We can do as of own. But coming to the therapeutic intervention, we have to some orders from the doctors or any other other physicians. And what are the therapeutic interventions? Means a plan of period of rest between the activity, because we have to give a rest to the patient, and activities increases the metabolic rate and oxygen requirements also. So you have to plan the period of rest between every activities, and maintain the head and elevation, because we encourage the patient to be on semi-Fowler's or Fowler's position. That will help the patient to breathe easily, and also promote the maximum lung expansions also. And administration of any ordered medicines, like short-acting to be adrenergic agonist, like albuterol or levobuterol or terbutaline, like that. And inhaled corticosteroids, as I discussed before. And anticipated need for the alternative treatment, life-threatening bronchospasm continues, means you have to check for this. General anesthesia. General anesthesia is used both dynamic hypertensives and profound hypercapnia that cannot be corrected by the increase of minute ventilation. And magnesium sulfate, we have injection form of magnesium sulfate rather than that powder. And magnesium sulfate is a good bronchodilating and anti-inflammatory one. We have you may use, but by the proper prescription we can use. We can't use as our own. By the doctor's prescriptions or from any other orders from the physician, you can use magnesium sulfate. And other thing, you have to only use at critical area, because the patient might have complications, anaphylactic complications. So you have to very careful on that. And HELOX, a helium oxygen gas. The use of helium oxygen gas, a less dense gas in nitrogen, and cause a decrease of airway resistance. This lessens the work of breathing. And how to prevent and coping. This is also an important one for for all the nurses. Warm up for 5 to 10 minutes. If you are doing exercise, means get warm up for 10 to 15, 5 to 10 minutes before itself, and have a cool down for 5 to 10 minutes afterwards. Your exercise finished, and drink a lot of water throughout the day. That will help you loosen your mucous membrane. So you have, if you are having any cardiac issues or kidney issues, you should consult your doctor. How much of water that he requires per day for 1 liter or 1 liter or 800 ml, like that. You have to check with your doctors, and exercise indoors in cold days, because the cold weather is also one of the causative trigger for bronchospasm. So when it was a cold weather, exercise indoors and wear scarves over your nose or mouth or while going outside, and ask if you are smoking, like that. Ask your doctor for advice to help quit smoking and stay away from anyone who is smoking. And if you are 65 years and older, or with you have any other chronic lung disease or any immune system problem, stay up to date of pneumococcal and hip vaccine, that is influenza vaccine. And this is an alternative therapy we are not using on here. It was widely used on Russia and Ukraine. This technique was introduced by one of the Russian physician. That is a Butico technique of breathing retraining exercise, consists of the following. And several actually these we have a lot of breathing techniques was there. Actually, like backwork breathing technique, or a lot of breathing technique was there, but they are not they are all still in study. But out of 4 study, it was 3 successful study. And the steps how to use Butico technique means, as a patient to have a several shallow breathe through nose for 10 seconds, and exhale the air after 10 seconds is up, and pinch your nose to prevent inhaling for 3 to 5 seconds until you feel first feeling of being in air anger, and repeat it for several times. While using this technique, we can also reduce the use of albuterol, because some of the studies says that we can reduce usage of albuterol or any other bronchodilators medication by using this Butico technique. And home care, while patient was getting out of the hospital, you have a lot of responsibility, and you have to educate the patient what are the things you have to do at home, and what will be the complications they are facing at home, like that we have to educate. Drinking a lot of water or other fluids, at least 10 glasses per day. During any attack, that will loosen your, as I said before, that will loosen your lung secretions. And taking prescribed medicines exactly. We have to educate the patient to not to quit the medicine. We have to encourage the patient to have medicines regularly and periodically. And if they are found to have any allergic towards the medicine, they have to they have to come and seek the healthcare personnel. And don't smoke. And taking prescribed medication exactly, we have to educate the patient about the importance of taking medications, because what will be happen, we have to educate what the things will happen if you quit this medicine or anything. Don't smoke, avoid smoking, being exposed to secondhand smokes also, that passive smokers. And if you are giving an inhaler, use exactly as it is, as was directed. If you the techniques, you have to educate the patient how to use the inhalers and all. Thank you. And any questions?
Ms. Manisha, that was really great to hear from you. You know, the very important and detailed nursing points, not only how you prevent patients getting these things, the bronchospasm, but also, you know, the use of inhalers, the use of medications, how you keep them comfortable, and look after their anxiety. All great points. So I'm sure there will be further questions. Ladies and gentlemen, I know some of you have joined us slightly later than we started, so welcome. If you have questions that you would like to ask, we will take them in the end, but it will be great to put those questions in the chat box so that we can then see as to what questions are coming in, and we can address them at the after Dr. Sai's talk. So it'll be great to have questions and discussion points if you want to raise in the chat box. Without further ado, can I invite? Sorry, Monisha, were you saying something?
I want to thank some people.
Sure.
First, initially, I thank Mrs. Captain Usha ma'am for nominating me to this webinar, and also my HOD, the lady who gave protective environment for us, Ms. Joy Kesia, HOD of nursing at Vanagaram Apollo. Thank you all.
So I'm sure Sai will join me in thanking all the individuals who make it all happen. So brilliant! Thank you very much indeed. Of course. So we now go on to Dr. Sai Haranath. Sai, welcome. Those of you who were not here at the beginning of the program, I will just briefly introduce Sai. He's a senior consultant based at Jubilee Hills in Hyderabad. Critical care specialist and pulmonologist. So, who would better tell us about bronchospasm if not Dr. Sai Haranath? Welcome, Sai. All yours. Thank you.
Thank you, Dr. Ravi. Just an audio check. Can you hear me okay?
Yeah.
Okay, great. I'm just going to try to share my slides and see if that works. I know some people had some issues with getting in. Let me just make sure this thing works. See my slides?
Yes.
Okay, let's just try to play them real quick here. Okay, do you see the first slide?
Yeah.
Okay, perfect. So thank you all again for joining in, and Monisha, excellent job. And I think you've pretty much covered everything, and there's nothing like hearing things twice. So you are going to hear a lot of repetition from what Monisha has shared. And this is a very common problem. Bronchospasm is something some of you might have asthma, and some of you might have undergone breathing difficulty. And in the COVID crisis, I'm sure we're all very worried when you get short of breath and hypoxic. So bronchospasm is just one component of feeling short of breath. And I'm just going to go through a little bit of the pathology of what happens, a little more review and a refresh from what Monisha shared in terms of what happens. And I've put in a couple of audio things. Let's see if they work, and we'll see if that makes a difference. So let's take this case of a woman, 45 years old. She comes into your OPD or your inpatient setting, and she has wheezing, and she's got symptoms of cough, and she's had 2 days of dust exposure. She's used inhalers in the past. She's been coughing up white phlegm, and she has no fever. Saturations are good. Pulse is okay. BP is not bad, but she's tachypnic. She's breathing a little bit fast, and she's having wheezing bilaterally, and she's using accessory muzzles. So have the picture of that patient in front of you as we go through this talk, because ultimately this is about fixing patients and their wheezing, fixing patients and their breathing difficulty. And so you can kind of understand how this can be done in a very efficient way. Now, you must remember that all that wheezes is not asthma. All that wheezes can be multiple other conditions. And it's important for you to recognize that, because you have to recognize the cause of the bronchospasm to treat it correctly. It could be asthma, of course. It can be an allergy, it can be anaphylaxis, it can be aspiration, especially in children. You can get, like, for example, peanuts, so other foreign bodies can go in. You can get an airway mass, which are a tumor that can do this. It can be stridor, which we'll look at very shortly. It can also be things like anxiety. People can cause their vocal cords to close and make it sound like wheezing. Many people who used to need to join the military in other countries many years ago would fake a wheeze so that they didn't get drafted into the military. So those are kinds of things you may come across. Now, where is the wheeze coming from? So wheeze can be, like a high-pitched sound, whistle-like. It can be like a harsh vibrating sound in stridor. The older term is rhonchi, which are a little lower pitched than wheezing, and you have secretions, you can hear it. Let me experiment and see if this works. I'm going to try to play this, see if you can hear it, let me know.
We can.
Go back. You can? Okay, very good. Let me just go back one slide here. Okay, let's play this again. So that's how a wheeze sounds. Let me play another sound for you. So that's stridor. Now you can see that the pitch is different, a little more vibrating. The sound is a little bit more intense. And if you look at the cycle of breathing, you have the inspiration and you have expiration or exhalation. And if there is an obstruction in one of those pathways, you end up with the difficulty that we talked about. If it's upper airway, you may hear wheezing, but you might even hear stridor. If it is in the area between inhalation, exhalation, say what we call the glottis or the subglottis, you might end up with stridor. If it's purely an expiratory sound, it generally is wheezing. And Monisha explained to you how the anatomy is located, where you get the blockages, and it's a very simple principle. So the pathophysiology is all because of what happens in physics. You have a tube, and if your tube you compress, the air velocity changes and you end up with sounds. Also, if there is inflammation in the airway, you can get a thickening of the mucous membrane, you get less space for the air to go through, and the pitch of the sound increases and you hear the wheezing. You can have other conditions like COPD, where normally your air tubes are all pulled apart by the elastic fibers. But if you have COPD from smoking, those fibers are destroyed and these tubes are not held open and they close when you breathe, especially when you breathe out, and you can end up with wheezing and also a condition called air trapping. So if you look at an X-ray of a person with COPD or asthma, you will see the diaphragm is not curved, it is flat. That's because they've been pushed down by the air that has been trapped. Now, there's something called the Bernoulli principle, which if you're going on an aeroplane, you're dependent on the Bernoulli principle. Anytime that you fly, your air, the wings of the aircraft have air going on the top and the bottom. But if you have a faster airspeed, the pressure goes down. So the lower pressure from the bottom of the wing pushes the plane up because the shape of the wing is curved and you get the air going faster on top. Likewise, in an air tube, in fact, there's a nice, if you Google it, you'll come across this experiment where they showed that if you have a tube that narrows down, but the volume of the air that has to go through is the same, you end up the speed increasing. And that is where the sound also changes. So this is like the anatomy and the Bernoulli principle, which creates the wheezing sound. Now, when you do get the wheezing, it is good that the air goes in. Unfortunately, sometimes what happens is the air gets trapped inside. You can get this diagnosed either with a CT scan where you do an inhalation, exhalation cuts. You can also look at it by just examining a patient, or if they're already on a ventilator, you can measure these things where the end exhalation lung volume keeps increasing. So the simple way to look at this is, I've just put a little slide of the James Bond movie where there's no time to exhale. In other words, you take a breath in, but you're not blowing it all out. So take an example of a balloon that you're blowing. You're blowing the balloon open, and then the balloon has a tendency to deflate. But what if you tie off the balloon and let the air stay in? But you only let a little bit of the air out. Over time, what's going to happen? This balloon's going to get bigger and bigger and bigger and bigger with the air getting trapped inside. And that is what is called dynamic hyperinflation. And your lung is going to be at a much bigger volume, which is what you see on the X-rays. And then you end up with complications, including things like pneumothorax, which we'll talk about. Just a quick audio video check. You guys can still hear me, right?
Yes.
Okay, perfect. So when you do have wheezing, now Monisha has gone through the entire list of things which can be done, and you need to reverse this narrowing. You also need to decrease the inflammation. You can give medicines to relax the muscles. They can be beta-2 agonists. You can also have muscarinic antagonists. You can give drug like magnesium. You can even use Lasix, for example, of furosemide, and there's been studies showing that might even help. You can also have anti-inflammatory steroids, and these can be nebulized, inhaled, or oral, or injected. And in addition, you have to correct the gas exchange problems, which are low oxygen, high carbon dioxide. Normal lung size, the size of a tennis court. These tubes they're talking about, the one tube, the trachea, splits into two, then it splits another 23 times and ends up in this little, thin fibrous layer, which is all bunched up like grapes, which you saw in the earlier pictures. And if you have a problem with asthma, you're not getting the air going in. If it gets really bad, then you have to put them on a ventilator or use non-invasive ventilation. So the pharmacologic rescue is using medicines we talked about, the bronchodilators, which can be short-acting or long-acting. Now there is a stepwise approach for asthma management from the outpatient to the inpatient. You can look at these various algorithms, but in general, the previous algorithms all talked about using short-acting bronchodilators. The newer data in the last 1 or 2 years is suggesting that we also use inhaled corticosteroids in addition to using short-acting bronchodilators. So the big change has been that use the steroids early, use the bronchodilators, and there are newer therapies coming out, including using biologics, which actually work on the mechanism of the asthma. They work on either the relaxation of the tubes, decrease the inflammation, control the allergy. Also, they talk about using newer therapies, including affecting the IgE molecule. The IgE molecule is one of the molecules involved in triggering allergy. Additionally, you can have ancillary treatments, including things like cromolyn. You can also have things like theophylline, aminophylline. These are all minor agents. They do have multiple side effects. They sometimes have very narrow therapeutic range to use. So it's important that you kind of be cautious when you're using it in this manner. The other mechanism for rescue is, of course, mechanical rescue. And the mechanical rescue is when the patient can't breathe, you need to help them with a mechanical ventilation. Those of you who are physicians may be interested in this wonderful paper from 2009 in the American Journal of Critical Care Medicine. This is about intubating and mechanically ventilating. Some very good principles are there. Now, clearly, why would you ventilate somebody? Well, they look bad. And that is often the #1 reason that you should intubate and ventilate somebody. Of course, if they have a cardiac arrest, if they have respiratory arrest, if they have altered sensorium, if they're exhausted with breathing, or if their lungs are not having any sounds. So if you have a silent chest, you have to definitely say that there is no air going in or out. You have to intubate them. There can be lab abnormalities, including things like low potassium from too much use of bronchodilators. You can also have acidosis. You can have severe low oxygen levels or very high carbon dioxide levels, despite everything that you've done. And you have to put them on a ventilator. When you put them on a ventilator, you have to choose the kind of medicine to sedate the patient, because some medicines can trigger bronchospasm. You can consider drugs like propofol, for example, and you have to also think about the intubation. Is it through the mouth or the nose? Whichever is easier and can be done more rapidly is something you should use. You have to think about using a larger tube, because we talked about how the resistance of the tubes goes up as they get narrower. So the larger tube, 8+ is ideal if possible. You have to kind of then decide what kind of settings you use on the ventilator. So the concept you have to remember in this entire presentation is dynamic hyperinflation. You need to allow the air to go in, but you also need to allow the air to come out. So you should use a low rate so that there is more time to exhale. You can use high flow so the air goes in faster. Use a higher amount of oxygen. Use a lower tidal volume so that you don't distend. The same principles like ARDS apply. However, since the lungs are normal, you can go to 6 to 8 ml per kilo ideal body weight. And ideal body weight depends on the height of the patient. It doesn't depend absolutely on the weight of the patient. So a 5-foot male ideal body weight is 50 kilos. A 5-foot female, the ideal body weight is 45.5 kilos. And for every inch on top of that, for male or female, you add 2.3 kg. This is a standard formula to calculate. If you're working in ICU, you should already be aware of this. You may need to use paralytics. What are paralytics? There are neuromuscular blockers. When you intubate a patient, you often use them. Sometimes in asthma, to keep the air pressures low, because you have a lung that is having tight tubes. If you push air in, you're going to blow the lung up like a balloon that's bursting. So you may need to help the patient avoid coughing and also slow down the breathing pattern and let the machine do all the work. You have to monitor the pressures on the ventilator. And for the purpose of this talk, just remember that you have to watch things like peak airway pressure, watch the plateau pressure, and look for autopeak. These are advanced concepts, but the audience is mixed. So I'm just going to share some of these facts also. Now, we talked about the medicines. You can use various medicines, which are all similar in generally the mechanism. They work on the mechanisms of the receptor blockade or triggering the receptor to relax the muscles. So albuterol, salbutamol, levosalbutamol, ipratropium, longer acting ones like formoterol, salmeterol, and of course, magnesium. Now, When you use the bronchodilators, you can even have short, long, or even ultra long acting over a 24-hour period. But there are some side effects, including tremor. You can have tachycardia, fast heartbeat, low potassium. One algorithm for people who have severe wheezing and severe bronchospasm is to use albuterol 2.5 to 5 milligram by nebulizer every 20 minutes for 3 doses over 1 hour. Then similar dose every 1 to 4 hours as needed. And you can use inhalers with multiple puffs, 6, 10 puffs even, instead of a nebulizer also. You can also hold the short-acting muscarinic antagonist when they're admitted and just focus on one kind of drug if necessary. You have to look at anti-inflammatory drugs also, and these include steroids. These can be inhaled or nebulized. A couple of examples of budesonide or fluticasone. If you're in the ICU, you can use injectable methylprednisolone, 60 to 80 milligram every 6 to 12 hours. Once they get, if they're better and you're just only admitting in the ward, you can use a lower dose, like 40 to 60 milligrams every 12 to 24 hours. Now, it's important to realize that we have moved away from extremely high doses of steroids. Previously, people would give very high doses, like 125 milligrams or 500 milligrams even. Generally, we don't need that much. These doses are adequate, and you have to be aware of the side effects of steroids, which include high glucose, mental confusion, difficulty sleeping, increasing the risk of infection. So if you're a diabetic, you have to be careful. People can get very confused in the ICU just from being in the ICU with delirium, and steroid use can make things worse. You also increase the risk of infection in these patients. You also have to look at the other extreme measures, including rescue things like Heliox, as mentioned earlier. It's a lower density gas, so it can get in through the tubes much more easily in the upper airways. So it may be helpful in that setting. Drugs like ketamine, which are used for anesthesia, are helpful. There are studies also showing that nebulized xylocaine, lidocaine, or lignocaine might also decrease the bronchospasm. The principles of ventilation, to repeat again, avoid barotrauma. Barotrauma is where you destroy the normal lung anatomy and break open tubes, and you end up with pneumothorax. Avoid hyperinflation. Try to avoid coughing because that can lead to pneumothorax. Monitor the secretions and watch for any hemodynamic effects. What do I mean by that? Well, when you're having people with low oxygen and high pressure, you can collapse the lung. When the lung collapses, you can push on the heart, as you can see in this X-ray here, where the patient is actually having a collapsed left-sided lung with a pneumothorax, where you see the dark area. It's pushing the heart to the other side. It can compress the entire heart, and you end up not having blood flow coming back. And what you also realize is that you need to emergently treat these. Sometimes a small needle in the second intercostal space on the left and right side, depending on which side the pneumothorax is. You also have the concept of auto-PEEP. Now, this is a little interesting thing where when you want to keep the lung distended, you need something called PEEP, which is positive end expiratory pressure. But if you keep pushing air in and there's no time for it to come out, because the tubes are narrow and don't allow it to come out, you get hyperinflation. And that hyperinflation causes the pressure from inside to push the air out, but it can't come out. And that leads to this dynamic hyperinflation, which pushes on the heart and can cause trouble with lowering the blood pressure and pneumothorax. And these need to be measured and treated emergently. Some definitions for our memory: PaO2 is dissolved oxygen in plasma, average is about 80 to 100. Anything more than 55 or 60 is enough. SaO2 is the percentage of available oxygen bound to the hemoglobin, and the normal range is 95 to 100%, but we are moving towards even lower, like 92, 93 is also okay. Almost most of the oxygen is bound to the hemoglobin, only a tiny bit is dissolved in the plasma. And SpO2, which you measure on the finger, is a non-invasive measure. You have to be aware that the non-invasive measure can have multiple false positive issues related to a ambient light, which can cause the reading to be wrong. You have somebody with atrial fibrillation, it can be wrong. Somebody has low blood pressure, the perfusion is bad, so the hands are very cold, you won't get a good reading. And I'm sure our nurses are completely aware of this. Normal ventilation, if you look at the ventilator waveform, is like mountain peaks. You can see that the air coming in and out, and that's how the volume pattern of the ventilator looks like. Likewise, you have the flow where the air goes in and the air comes out, and you typically will see this curved pattern, and anybody who has seen a PFT will know that the same pattern you're going to see on the ventilator when you look at the ventilator graphics also. This is one of the most important slides. Anybody with asthma, you have to adjust the ventilator standing at the bedside. I remember as a trainee many, many years ago, a young woman who was on a ventilator, suddenly her blood pressure dropped. And I had literally no idea what was going on, but my senior doctor quickly said she probably has a pneumothorax, and we listened to her lungs, and rightfully so, the left-sided lung did not have any breath sounds. So we put an emergency tube and relaxed it. How do we pick it up? There's an alarm going off, the high pressure alarm. The high pressure alarm suggests that there is high pressure in the circuit. That can be from the patient biting on the tube. It can be from bronchospasm. It can be from a pneumothorax. It can also be that the air supply is not good. There's a mucus plug in the tube, for example. So always be at the bedside and don't ignore any alarms. Very important that you confirm that the alarm is audible. You can adjust the alarm settings so that you're not bothered all the time with something you know that is abnormal. If somebody's heart rate is 120 at baseline and it's only going to 124, you can change your alarm settings with the help of your doctors to do that. But also make sure that you go to the bedside, look for disconnection, look for water in the tubing, and definitely make sure that there is no clear evidence of pneumothorax or hypoventilation or even autopeep. Now, bronchospasm can lead to VQ mismatch, which is air and oxygen delivery from the blood vessels can be different. So if you have somebody with a bronchospasm, the tube is closed, you're not getting air in there, blood is flowing, but that blood is not able to get oxygen or blow off the carbon dioxide, and the patient's carbon dioxide keeps going up. You can have secondary causes like pulmonary embolism. You can get atelectasis, where the tubes get plugged from thick mucus, which is produced by the goblet cells, as Monisha mentioned earlier, where the tubes block off the parts of the lung and you end up with difficulty in air getting supplied. So we have so far gone through the mechanisms of asthma and severe bronchospasm. We talked about everything that reasons is not asthma. You need to look at other medical conditions that can also do it, including congestive heart failure, COPD. There's also the asthma COPD overlap. You can look for aspiration and anaphylaxis. We also talked about simple treatments, including bronchodilation and anti-inflammatory medicines. We talked about the concept of dynamic hyperinflation. We are also talking now about how you can get atelectasis from mucus plugging. Let's take the case of a 25-year-old woman with hypotension and wheeze, like I mentioned. Listen for silence. You need to listen that there is no air entry going on, which is a medical emergency. You can often do urgent decompression. You can also kind of pull the patient off the ventilator, meaning disconnect the ventilator and let the trapped air come outside. That's another way to handle autopeep. And you do need to do emergency measures using a small needle, and then you need to use a larger chest tube. The hemodynamic complications we talked about, because of the pressure of the lung, the right side of the heart and the inferior vena cava or the superior vena cava as they come through don't have enough volume because the lungs are pushing on them, the pressure is high, you're not having a preload. The heart is not getting any blood flow, your blood pressure can drop. Sometimes you have to also, like I said earlier, disconnect the ventilator so that you decrease this peep. Still advanced concept, but some of the doctors may find this useful down the line. Pneumothorax, we talked about using a measurement of the high peak airway pressure. You should check on the ventilator and watch for barotrauma. This is a little interesting thing. Let us see if it works. All of you can, I think, see this. Let me see if this works. I want you to see this video and we'll have a quick chat after that.
This is an awareness test. How many passes does the team in white make?
Go!
The answer is 13.
Did everybody see that? Dr. Mahajan, was that visible?
Yes, that was.
Okay, did you count?
I did.
Okay, so let's see what people think, but let's keep watching this. There's a lesson here, you'll know in 10 seconds.
But did you see the moonwalking bear?
Go!
This is an ad from the UK to look out for cyclists. It says it's easy to miss what you're not looking for. In other words, if you don't know what you're looking for, you're not going to find it. it's very important that you increase your knowledge base on simple things, including things like asthma, for example. And I think it's important if you look at that. So I just want to share this fact that it's important that you keep an eye out on these things. And of course, observation skills are very important for doctors and nurses. So you can pick up the subtle signs that patients are having trouble, because oftentimes you have to intubate a patient before you get your lab work back. And if you look like they're looking very tired, check for allergens, check the volume status, make sure they're not dehydrated, make sure that the reason for their worsening of their asthma and the bronchospasm is not something like poor compliance. They're not taking their medicines or they're using it incorrectly, especially inhalers. And Monisha shared with you how these should be done correctly. Now, in terms of bronchospasm management, it's important to check the history, examine the patient, do the interventions and follow up, try to define their prior asthma control, to get a history if they previously needed intubation, because it's possible they may need to get intubation if they've already previously intubated. Do a quick examination that you can clarify that they're going to get worse or not. Check and see if they're actually getting worse very quickly. And you have to observe their breathing rate and respiratory rate and oxygen level. Plan intubation and the settings on the ventilator that we talked about. Also do close follow-up of complications like the tube going the wrong place or having a very high pressure, for example. And then you figure out, when can I start lowering care? When can I lower the steroid dose? When can I cut down the oxygen level? When can I take them off the ventilator? These are things that need to look at. Now, there is some good evidence for some of these facts. Only 2% of chest x-rays in acute asthma are abnormal. So not everybody needs a chest x-ray. An examination should generally be enough unless you're suspecting a complication like a pneumothorax. Aim for an oxygen saturation of over 92%. And if it's someone who's pregnant, aim for 95%. And in pregnancy, you should use the same therapy for asthma and you treat the patient first. Keep a lower oxygen goal to prevent hypercapnia, because if you use too much oxygen, there's an interesting concept where the oxygen and carbon dioxide are linked. We can talk about this offline sometime, where you can create a high carbon dioxide level by having too much of oxygen delivered. High doses of short-acting bronchodilators can cause a low potassium and can also increase the lactic acid. So a lot of times you see high lactic acid, which is not from sepsis, but from asthma, overuse of muscles, and from bronchodilators. You don't need a very high dose of the steroid. Oral and IV steroid have similar absorption. So if you're able to give it orally, that should be good enough. Steroids given very early seem to help. And you may sometimes want to try a short trial of the non-invasive ventilator with CPAP to see if that makes a difference. And there are many investigation agents, including Heliox, ketamine, and even general anesthesia like halothane that can be considered. Once they get discharged and they're better, you need to prevent the recurrence and assess the environmental control. If they're allergic to cockroaches or peanuts, you want to make sure that they're not around. Make sure they're taking the right dose of the medicine. Work on the technique, because these are very preventable. It costs you nothing to teach them this, but one ICU stay will cost them several lakhs of rupees. Look for secondary factors, including acid reflux, aspiration, allergies to something, parasitic infections, very common in India. High eosinophil counts, including sputum eosinophil measurement. There are also ways to check something called the FeNO. You can check the nitric oxide in the exhaled breath to look for inflammation. Look for a condition called tracheobronchomalacia, where the tubes don't stay open because they don't have enough muscle or there's not enough cartilage, so they collapse very easily. Also look for cardiac disease. Often you can have ischemia presenting like asthma or wheezing. There's no need for a steroid taper, which is lowering the dose if you're using it only for less than 3 weeks. And in general, people need about 5 to 7 days of steroid use. There are newer approaches to treating bronchospasm, including techniques like bronchial thermoplasty, which is available in the Apollo system, where you heat the airways to prevent the muscle spasm. There are roles for anti-IgE therapy with newer biologics like we talked about. And of course, anesthesia in extreme approaches to somebody who's not improving. Let's take another case of a 57-year-old woman with a wheeze and weight loss. We want to check and see, is it on one side? Are there any other signs, like, for example, ptosis of the eye or clearly lymph nodes? Lung cancer can occur, and it can occur in non-smoking women. And it can be from secondary exposure to tobacco, or in India, a lot of that can be related to biomass or burning wood, etc. when you're cooking. And you can be having a localized wheeze, and that can be from a mass. Now with the COVID crisis, many people got intubated and they got tracheostomies. They can often get subglottic narrowing, and that can have difficulty breathing, and sometimes you can get noise when they actually breathe. All of these conditions, if detected early, can be cured. And of course, you can take a case of a male who is a former smoker, who can have COPD also, where they have low oxygen, high carbon dioxide, and wheezing, but treatment mostly similar. continue the home approach they were taking, including all the medicines they were on. Look for secondary problems, including heart failure and pulmonary embolism, which can occur in 1 in 4 people with asthma and COPD for COPD exacerbation. And I think it's important to refresh what I just shared earlier. What the mind does not know, the eye does not see, and the ear does not hear. So the sounds I played earlier, for some of you who have never heard a wheeze, try to go to the ward and ask your doctors, if you're a nurse, to teach you what a wheeze sounds like, because it's very important that you know and recognize this in an easy way. Especially if somebody has obstruction causing stridor, you have to act very quickly. So thank you. And I think this whole series of the Apollo Knowledge series is about never stopping to learn, because never stop learning, because life never stops teaching. I greatly appreciate your time. And thank you again, Dr. Mahajan, Monisha and Jude for coordinating this, and for the Apollo system for giving us all an opportunity to learn and share and take our knowledge further. Glad to answer any questions. Thank you very much.
Thank you very much, Sai, for taking the step from where Monisha ended her talk, which were about the nursing points, and then take it to another level where you've dealt with it so beautifully, the breadth and the depth of the topic. So, and you both speakers, thank you very much for leaving plenty of time for discussion, and that is really important. So I'm hoping that we will have an interactive next few minutes where we can share our knowledge and share our questions or doubts or whatever we may have. Please put your questions in the chat box, because otherwise you're muted, and we need to do that to keep the platform quiet and audible to everyone. So please keep putting your questions. So I have one question which is come to the chat box, which is, how does lung work in Buteyko technique? So Sai, do you want to take that on? Or?
Yeah, honestly, I have not used this technique to treat asthma, but what I would think is that this helps in decreasing the dynamic hyperinflation. Essentially, you're allowing the lung to not get overinflated, and it's all physics. If you look at it, the diaphragm shape is like a curve. And I know some of you might have kids who are studying math and physics. You'll know that there's something called the Laplace law. So the Laplace law states that the radius is proportional to the force. So if you have a curve and you have a radius that's 4 centimeters, for example, you have a good force, muscle can act. But you have somebody with hyperinflation, the diaphragm gets flat. It doesn't have much room to play, and it's not able to push down. So the techniques where you're exhaling out and emptying the lungs out probably help with allowing the lungs to kind of stay at an optimal volume, so that they're totally expanded, that there's no more place to expand. That, I think, would be one of the ways it might be working. But again, I have not used this particular name technique, and I think it's an ancillary method compared to the standard measures which I've mentioned to the world.
Thank you. Thank you. It is also called a method to retrain your muscles or retrain your breathing pattern. But yes, as you say, I think hyperinflation plays an important role in patients, how they feel, their muscle exhaustion and the breathlessness that they have. So yeah, brilliant. Thank you. I know that many of you had some issues in logging on earlier, and that was to do with the updated date, and that's what I believe, and change in the link. However, we'll be looking at what caused it, and sincere apologies to those who were not able to hear first few minutes of this talk. But thank you, Jude, for correcting this. And Jude, I know, went to the other side and gave them the correct address. So brilliant. Thank you. Good to have you all here. I have a little, your video, Sai, was excellent, where the moonwalking bear just came in, and everybody was so fixed on the task of counting that you miss the bear in the room. So any working examples of how people, if they get so task fixation while you are treating patient with acute bronchospasm, that you might miss certain complications?
Yeah, I think, Monisha, you want to take that as a nurse. What do you do at the bedside when you're seeing a patient what do you think is the most important things that you observed as a, like the practical benefit?
You need to maybe unmute.
Can you hear me, Manisha?
Yes.
Just asking just some practical tips for our nurses in terms of observation when somebody's having breathing difficulty. What would you think is the number one thing to do? Say somebody in your ICU.
We should look for the patient who's having some high levels of respiratory rate. By that, the patient was a tachypneic or anything, you should know. And the chest retractions we have to watch.
Great. So I think
And
those are good points. Yeah, go ahead, please.
And the breath sounds also we have to.
Sure. Sure. So typically, most nurses are not listening to the lungs. They're only listening to using stethoscope or checking the BP. But I think it's important to start listening to lungs so people know what they are. And the lung sounds are pretty simple. You either have wheeze or you have normal breath sounds or you have crackles, which are, could be fluid and secretions. It's important that you all start requesting your teams to learn that. And that's one big step you can take in terms of increasing the quality of the care we are delivering. The second thing to really remember is in terms of observation is, as you mentioned, the respiratory rate and also use of accessory muscles. So accessory muscles like the sternocleidomastoid. Now, when people start using those muscles, their lung reserve capacity has gone down quite a bit. Dr. Mahajan, as an anesthesiologist, I'm sure you can tell us that, that's something you watch for, right? When you're seeing patients with breathing difficulty.
Absolutely. Yes. No, I agree.
So I think so those are things you can look for. And oftentimes a patient may not be able to speak. And when they can't speak, it may be that it's not that they're okay, it's that they're not okay, that they're having difficulty. So if you look at a crisis situation, I went through a training once where they had one patient who was screaming with pain, and next to him was another patient who was very quiet. Everybody went to the screaming patient and ignored the quiet patient. So it's important that you keep your eyes open for the different things that could be going on in an ICU. And somebody who has asthma may not be able to speak. They can't speak in full sentences. Watch the oxygen level. The oxygen level may not drop right away, especially if you put them on a mask, for example. But also, I think what Monisha mentioned about the respiratory rate is very important. I know all of us put 20, but that's the universal number of breaths we take, but it's really not 20. Now, if you take your own breath, it's probably 12 or 14 or something of that sort. So what you want to also do is definitely look for tachypnea and use the principle. It's very important. I think the number one thing is communication. Communicate with the patient and find out what's going on. Communicate with your team, with the doctor. If they looks like they need intubation, talk to the anesthesiologist early on, because sometimes they have to prepare for a difficult intubation, or they need to prep the kind of drugs that they need, or even talk about the ventilator setting so they don't cause damage to the lung initially.
Thank you. Let me put a scene to you, and you touched on that in your presentations, which you get quite often with patients who are admitted to critical care and with exacerbated COPD. So you've got a patient, an alarm that shows you high pressure, and so the ventilator is beeping all the time, giving you the alarm. You're seeing the high pressure, and when you look at the patient, you actually can't see much air going in or going out. Or coming out, and if you then look at the tidal volume on the ventilator, it's actually really very, very small, and the triggers are all over the place depending upon what pressures you put the triggers on. So the ventilator alarms are not only showing high pressure, sometimes they're showing high rate, and there are mixture of alarms. Now that is something that if you get a junior doctor to come in and have a look, what will be your advice to the bedside nurse or to the junior doctors as to in terms of methodology, as to where they should start and where they should end?
Sure. I think in general, it begins with the patient always. So you want to examine the patient right away to see what's going on. If they're already on the ventilator, you want to make sure the tube's in place, it hasn't slipped out or slipped into, say, the right main stem. You also want to make sure that the connections are appropriate. and that there's no mucus plugging, for example. And then once you listen to the lungs and you realize that this is either wheezing or not wheezing, you want to kind of treat that cause. But you have to look for secondary things, including things like a pneumothorax. And you also want to make sure that the tube itself is not being, sometimes people bite the tubes if that's going on. So those are multiple there's ways to do it. And the ventilator waveforms are actually very helpful in diagnosing these things, and the alarms are very helpful in diagnosing. I have several of my critical care colleagues who are actually signed on. I see in their chat list. And if any of them wants to pipe up and mention something, please go ahead. I'm not going to name any names, but if you want to speak up and share your experience, please feel free to share your experience of how you dealt with the high peak airway pressure. I'll give about 10 seconds and I want to pull some names up.
In the meantime, I can't help mentioning that there have been some really complimentary messages in the chat box, people thanking our speakers today, Ms. Monisha and Dr. Sai, and that's really heartening to see. Also, it would be good to know, how do you think, because we're just at the starting point and we're on our learning curves, as we would say. So any comments regarding how we can improve will be really appreciated. You can email us or email Jude and let us know. Brilliant. So, Sai, back to you.
I'm going to ask Dr. Deepak. Dr. Deepak, are you able to, I don't know if he can unmute himself. Jude, can you unmute Dr. Deepak? There he is. Dr. Deepak is one of my colleagues at Apollo Hyderabad, senior consultant, very well trained in multiple specialties, including internal medicine, critical care. So Deepak, you want to add some insights on high peak airway pressures and asthma and your approach to it? Jude, can you unmute Dr. Deepak if possible? Well, you can just start typing Deepak in the chat. There is unmuted. Perfect. Yeah, Deepak, go ahead, please.
Good evening, everyone. Good evening, Professor, Sai sir, and sister. It's been a pleasure. I think one of the best lectures I have seen in the recent past and heard in the recent past. Practical points, as Sai sir already has pointed out, I think the observation and anticipation is the one which usually makes a difference. So from whatever the experience I have, the experience makes a difference. So to anticipate which patient may actually develop the complication is what matters. And when a patient is on ventilator, consciously and cautiously monitoring the curves, waveforms, whenever you have a alarm rising, you should not reflexively go and switch off the alarm, rather than just take a minute there and assess what is going on. And we always train our junior trainees to develop an approach of man, machine, and circuit. So always go and see the man first, see if it is correlating with the alarm, see is correlating with the whatever the event it is. Then check the machine. Many of the times we find that the connections are not there. Maybe the electricity has switched on something. Then ultimately the circuit. Many of the times we find there was a panic. Ultimately the circuit is just simply disconnected. You connect it and it gets transferred. So these are the simple points I would like to point it out, and my congratulations to you.
Thank you, Deepak. Excellent points. And Professor, I'm going to see if one of the other nurses wants to comment. Ms. Pinaki, are you online? If you have any suggestions, any thoughts?
So, Jude, if you could unmute Ms. Pinaki, please.
Sure, sir.
And Professor, I think the chat network, you put in information about the website, which has a lot of information on critical care. It has protocols, it has details about all the different programs we're doing. So I think it's a well done site. There's a newsletter that's out there. We recently had the inauguration, etc. So let's see if Ms. Pinaki is unmuted, or I don't see her unmuted yet.
Sir, namaste. Before Ms. Pinaki can actually come, I'm Joy, the Chief of Nursing here at Vanagaram Apollo. And this is my staff, Monisha. So namaste to you, sir, and thank you so much for the opportunity given to our unit to actually be involved in this particular program. Sir, I have been a participant of the program and I've thoroughly enjoyed it, taking down notes both from my own staff and also from Dr. Sai. And sir, thank you so much for knowledge sharing that has occurred. Our heartfelt thanks to Captain Usha Banerjee, who's really been catapulting the entire team to make sure we really know the intricacies of our own subject. And thanks to Sister Muthuram also, who has been really tirelessly coordinating with us and helping us to work with each other, although we really haven't met each other very much. Thanks to Jude. Thank you so much for being in constant connect with us. So once again, sir, our entire team wants to thank you. Thank you so much.
No, thank you. And on behalf of the steering group, and also on behalf of our speakers, if I can, thank you all for being here. So we still have a few more minutes for before we conclude this program. So if I could ask Monisha, please, as somebody who is, who's trained in the nursing, so you would say that there are some basic skills that you require, some intermediate skills, and some advanced skills. So basic skills are something that we will require with our nurses who are in our partner nursing homes, let's say, outside Apollo network. So if you were to think of some basic skills that you would like nurses from in the outside the Apollo network to learn in managing patients with respiratory illnesses, what would those be, please?
Jude, we might have to unmute Monisha again.
Hi, good afternoon. I'm Pinaki from Guwahati unit.
Hi, Pinaki. Yes. Hello.
I had trouble in unmuting, so I'm very sorry. But I was able to listen throughout the presentation. It is really, really wonderful. And Dr. Sai, we are always happy to hear from you. As usual, you are very active in the steering committee as well as all the programs. So today also it was not exceptional. We were very, very happy. Actually, what I feel the nursing community must learn very thoroughly about the identification of respiratory problem, because most importantly, I think we miss some time in identifying the first stage or in the early time. So then, people get into the stage of respiratory failure. So then I think it's become very difficult for anyone to really treat. So we have seen, and particularly COVID time, we have seen many stages where SpO2 was dropping and we were not able to pick up at that particular time. And then, patient ends up with high flow of oxygen, intubation, and so on. And not only that, I think respiratory related disease, I think each and every nurses need to learn. And this was one of the wonderful forum where Dr. Sai gave fantastic information, as well as he had shown such a wonderful video, which is admirable. And I'm really thankful to each one of you, and nurses are involved in, training, imparting training, and people are looking into have better information and knowledge in the subject. So thank you once again, Dr. Ravi, Professor Ravi Rajan, where we are always proud to be with you, sir, in this every forum. And today also was awesome. And I congratulate Ms. Manisha as well as Dr. Sai for a very good presentation. Thank you so much.
No,
thank you.
Thank you, Ms. Pinaki. So just for the information for all the people who are on this call, one of the things that we are doing with telehealth is and Ms. Pinaki is involved in it, and Ms. Muthuram, we are having 3 different levels of programs for nursing care. So one would be the basic skills and the intermediate skills and the advanced skills. So watch the space, please. And those programs will be available for the nurses, not only from Apollo network, but also for the hospitals and nursing homes outside of the Apollo network. So just watch the space and bear with us, but I thought I just plant that in, and it will be very, very important, as Ms. Pinaki has mentioned, and that many a times we write down the scores, we write down the early warning scores, we write down the heart rate, the blood pressure, we write down the respiratory rate, but then we don't know whether or not we have reached a point where it triggers further action. I think that is very important, where you realize now I need to get some help, and it is catching the things before they become really hopeless. And that is where the success comes in critical care. So it's been really, it's been pleasure to hear both our speakers today. I can see Ms. Muthuram is come on screen. Ma'am, if you would like to say a few words, that will be great. Jude, can you help that?
Good evening and namaste, sir. Nice seeing this. We grow up in the academic presentations, and also I would like to say my remarks like it is very essential for the critical care nurse in the bedside to auscultate the chest. That's very important. We need to impart our nurses on daily basis whenever they check temperature, pulse, respiration. Along with that, chest auscultation to be made and notes to be put there. So any changes in that, they should be. Also alarms, which plays very important role. And sometimes we compromise putting the people two patients, one nurse. Maybe the person held up in the other bedside. This patient should not be neglected. So we must ensure when the nurse, I would like to advise the nurses, if they are held up in a time spending procedures with another patient, the patient who is not attended should be monitored by the neighbor nurse. So that also we must give a carry home point for the nurses, so that every second of respiratory illness, which damages not only the respiratory system, also the brain, the oxygenation to the brain. So we should impart them it should be very essential to identify, not to avoid the alarms, and any small changes in the respiratory system should be brought to the notice of the clinician and take measures on time. So that's what the important one I would like to emphasize. And it is really great to see our nurses given a place for us to share our opinion and views. We are really grateful to you.
But I think that what you've just said, Ms. Muthuram, is so important. And it goes back to the video that Sai showed. You know, the situational awareness is key. So, and it usually happens that if there is an emergency or something, that your attention is diverted, you get so task fixed that you lose the awareness of what else is going on around you. So if you are fixated in, let's say, dealing with a difficult intubation, you forget to see, you know, what the saturations are, where the blood pressure is. So when you do not take those things into account, that is where things are likely to go wrong. So if you are fixated, get somebody else to look at things around that, and so that they are not fixated at the same time, and they can pick up what's going wrong. So you're absolutely right. If you are having to leave one bed to help with the other bed, not everybody just should concentrate on that particular bed. Somebody still has to watch this particular patient, and you're absolutely right. And that's how you deal with situational awareness. So same as if somebody was to count the number of times the ball is passed, somebody should be watching. Is there anything else going on in the room? And not everybody just starts counting, and then you miss something big going on in the room. So situational awareness, great lesson to learn in dealing with any emergency, and in particular, you know, the emergency which catches our attention, such as bronchospasm. Sai, if you...
I had a quick question, actually. It's more for my learning. See, I train in the US. I do remote intensive care for the US, and nurses there clearly are doing a lot of the work for the doctors, plenty of work. India too, I know many nurses are doing a lot, but I have really not seen that much of auscultation done by the nurse. I'm just curious, is it not taught in nursing schools, or is it not promoted? If it isn't, Dr. Ravi, I think this is a good opportunity for us to come up with a basic auscultation course for nurses in our system, where we teach them heart sounds and lung sounds. It can be a 20-30 minute thing with plenty of audio resources out there. And, you know, like the more and more we do these webinars, I realize that other than just the knowledge thing, we need to move one step ahead. And perhaps one outcome from today's webinar is Apollo Systems becomes the #1 system where nurses are allowed to auscultate and listen for lung sounds and heart sounds. maybe that's the outcome of this webinar, even more than the bronchospasm management. Any of the nurses want to comment? In your training, do they teach you to auscultate? Joy, Ms. Manisha?
Yes, sir, they are trained. In fact, that's part of our very basic foundational skills, which is taught in the first year, wherein we are taught inspection, auscultation, palpation, and percussion. Only with these four, we basically need to do the assessment. We are not taught to use, the lab values or the MRI or the CT. It's basically touch and go method, and that's exactly what I was taught, and the team is also being taught. But as you rightly said, yes, we could really promote it to make sure they are empowered in the right way, and that our nurses can feel confident to actually use the stethoscope. Today, they use it actually speaking only to check, auscultation very rarely, or probably to do blood pressure.
Yeah.
So it's a beautiful thought that you're giving us, and we can really, take it forward, sir. It's definitely the need of the hour, and it will be really helpful for all of us also to, train and retrain our teams.
Yeah,
absolutely. And I think that's the good thing we can. Dr. Ravi, you can take it forward from there and see how.
Excuse me, sir. I'm Uttaram. I would like to top up that point. Now, when the nurses are getting enrolled in the nursing curriculum in the college, first thing they take the pocket articles, stethoscope with them. And they are taught in the initial period of examination of the patient, how to auscultate. I think we need to get them into the practice of checking auscultations on the day-to-day practice. So I think it is with our in our leadership team of us to inculcate that habit and bring them up to that. And we do have a nursing excellence certification program for the hospital. In that, the emphasis is given that every nurse must auscultate not only the critical care patients, even the patients in the other areas, means ward areas. So that is the practice. I think it lies with the nursing leaders. We must bring up that practice.
So maybe the way forward, and we can discuss this, of course, but the way forward could be that in your nursing observation chart, where you say respiratory rate and SpO2, you also put in something like breath sounds, or we can work out, what, but which means that individual has to do the auscultation before they can write that observation down. That will just help, people feel more confident in doing so, but also more confident in reporting. And, you will be surprised how many times things get picked up. It's small collapse of one of the areas in the lungs or the secretions, which then lead to something bigger, which can be picked up quite earlier on with regular auscultation. And those things are not visible on everyday chest X-ray, even because X-ray findings come a little bit later on. So you could pick those up quite early on. Very good point, Sai. We should, Ms. Muthuram, we should just, see the logistics as to how we make sure that not only that this is taught, which is, it is done, but it is practiced with confidence, and where we take it from here. But it's good learning from today's webinar. It's been just brilliant.
Ravi, is there one more person wanting to speak? Binsi, are you trying to say something?
Please, yes.
Namaste, sir. Namaste, sir. I am Sister Binsi Joseph, working in Apollo First Medical Hospital as an in-charge nurse, sir. Actually, this is the first time I am attending webinar. I am very much thankful to Dr. Madangi. She only provided me this link, sir. I have learned a lot of information through this from Dr. Sai and Joy sister. So thank you so much. Thank you very much on the behalf of my team, sir. Definitely, so definitely I'm going to teach my girls like whatever you taught me as a PPT presentation. Definitely, thank you so much, sir. Thank you, sir. This is the first experience.
Thank you.
It's very heartening to hear those comments, and if one individual gets any benefit out of this time, it's time worth spent. So but I'm seeing here certainly more than one individual. I'm sure the number of logs on that we have, there are more people on each site. So the fact that this is going, and this is happening on pan-India basis in an integrated way, teams coming from different cities, and from different disciplines, that is good. We need to move further from doctors and nurses to start bringing physiotherapists, nutritionists, psychologists, other people who have so much of role to play in critical care as and when we get the topics. So please suggest us the topics as well. I know these series is fixed until February, but I'll be very open to the topics that you might suggest and where we can take, how we can take it further. So this is ongoing. So no information is going to be lost. So please give us your feedback and please send us the topics that you would like to hear, which will be great.
Sure, thank you.
The last 1 or 2 minutes, I will let my speakers today take charge and conclude it. So Monisha, please.
Thank you so much for giving me this opportunity. Actually, this is the first time I'm presenting a pan-India webinar, and my heartfelt thanks to Captain Usha Banerjee ma'am and also my HOD Ms. Joy KCM. Thank you, Dr. Sai and Dr. Ravi Mahajan sir, and also Mr. Jude.
Thank you indeed. Thank you. Sai, final words.
Oh, thank you again, Dr. Ravi, for coordinating this and wonderfully moderating. Thank you, Monisha, for wonderful slides, and thanks for very comprehensive overview. And thanks to all the teams who have attended today. And I think the general message that I like to remind myself in critical care is that it is critical to care. And we have to remind ourselves that it is critical to care, and anything that we do, if we put in the little empathy and the compassion, the experience is good for both ourselves and the patients. Thank you.
With those final words, ladies and gentlemen, thank you very much. Till the next one. So keep looking for the next program that we have. Jude, can you tell us quickly, if you have that information, when are we having the next program on the series?
Hello, sir. We are having the 2 programs in the month of November, sir. And there's one on the 3rd of November. I'm just pulling that up.
It's okay. So we'll look forward to having you all back on 3rd of November.
On COVID-19 and critical care by Dr. Ajay Padmanabhan from our Apollo Main Hospital, Chennai, and Ms. Kavita Bhattacharjee from Apollo Gleneagles, Kolkata. The moderator would be Dr. Sai Haranath. 24th November, we have the topic, which is transfer of critically ill by Dr. R. Pratima from Apollo OMR, Chennai, and Ms. Mikiben Patel from Apollo Hospitals, Ahmedabad. The moderator would be Dr. N. Ramakrishnan from Apollo, Chennai.
Brilliant. So here is the information for the month of November. So I'm looking forward to all of you joining again with even more of your colleagues. So look forward to seeing you all. Thank you for making this program a real success. So many participants and speakers, fully engaged till the end. Thank you very much indeed. Take care.
Thank you, sir.
Thank you, sir. Thank you so much.